Today in this lecture, we will talk about the role of angiotensin 2 and aldosterone in controlling extracellular fluid osmolarity and sodium concentration. This lecture simply states that sodium concentration in the plasma or plasma osmolarity is mainly controlled by osmoreceptor ADH and thirst mechanism rather than angiotensin 2 and aldosterone. And this thing has been shown with the help of this graph, which shows that even if we block the angiotensin 2 and aldosterone pathway, still there will be very little difference in plasma sodium concentration and plasma osmolarity. This graph is showing the plasma sodium concentration on the y-axis and sodium intake on the x-axis, and it is showing that normally the plasma sodium concentration is maintained within narrow limit. The concentration is maintained within a very narrow limit, and it is not increasing or decreasing despite of increasing the sodium intake, so many times. So the sodium intake was here at 30 milliequivalent per liter, and the sodium concentration in plasma was here. Now the intake has been increased to around 210 milliequivalent per liter, but still the plasma osmolarity or the plasma sodium concentration remains the same, or there is very little difference. Now, even if we block the angiotensin 2 and aldosterone, if we block them and they are not functioning, and then we start increasing the intake of sodium, still there is very little difference. In the plasma sodium concentration. You see the concentration remains within a narrow limit despite of increasing the uptake of sodium with and without functioning angiotensin and aldosterone pathways. See here, both the pathways are normal. Here, both of the pathways are blocked. Now, this lecture is the complete opposite of our previous lecture, in which we discussed the response of osmoreceptor ADH and thirst mechanism in controlling the plasma osmolarity. Here, we discussed in our last lecture that when the ADH pathway and the thirst mechanism are intact, the plasma sodium concentration is maintained within a narrow limit. But if both these pathways are blocked, then with the increasing concentration, in the increasing uptake of sodium, there is a very, very big change in the plasma sodium concentration. The change in plasma sodium concentration and the change in osmolarity is very big if the ADH and a thirst mechanism are blocked. If they are blocked, the change in concentration is very big as compared to when they are functioning or they are normal here. So, but here, when we are discussing the angiotensin 2 and aldosterone, if the pathways, if they are functioning or blocked, in either case, there is very little role. Now, why is it that the angiotensin and aldosterone have very little importance? Because they normally increase the renal reabsorption and they decrease the renal loss of sodium from the kidney. So normally the angiotensin and aldosterone will help in increasing the reabsorption of sodium and water from the kidneys, and they will decrease the losses of sodium through the kidneys. So they overall increase the amount of sodium in the blood. They are overall increasing the amount of sodium in the blood. Now their importance in the sodium concentration is very less, and it is only in very extreme condition. So they are important. The angiotensin and aldosterone are important in controlling the amount of sodium in the plasma, but they have very little role in the concentration. So they only increase the amount of sodium. And it is because that even if we block the system, as we discussed, that even if we block these systems, sodium concentration can still be regulated despite of increasing uptake. Despite of increasing the uptake, there is maintained concentration despite of both these pathways blocked. Functioning or blocked, both have very minimal role. The big role is played by the ADH and thirst mechanism. Now, why have they minimal role? Because both increase sodium and water reabsorption. They increase the amount of sodium in the plasma, but at the same time they increase the amount of water. So both of them, they nullify each other's effect, and there is very minimal role. There is very minimal effect on the concentration of plasma, the concentration of the osmolarity of plasma. Now, with functioning thirst and ADH pathway, the increased sodium concentration is compensated by increased water and increased ADH. Now, when both the ADH and the thirst mechanisms are functioning, any change in the sodium concentration is corrected with the help of ADH and thirst mechanism. And these two mechanisms increases the amount of water, so the effect on concentration is minimal. And this thing has been shown in conditions like primary aldosteronism. In primary aldosteronism, there is a very high amount of aldosterone in the plasma, but there is very minimal change in the concentration of sodium, plasma sodium concentration. So primary aldosteronism is a condition in which there is very high aldosterone. The amount of aldosterone in the blood is very high, but the change in concentration of sodium is very minimal despite of very high increase in aldosterone. And that is again proving that the role the angiotensin and aldosterone has in maintaining plasma concentration, plasma sodium concentration and plasma osmolarity is very, very minimal. Now there are only few exceptions. In extreme aldosterone deficiency, there is very big loss of sodium in urine, and it leads to high amount of ADH secretion, and it leads to a lot of water reabsorption, and it leads to a lot of reabsorption of water, which leads to a very high decrease in sodium concentration. So the whole pathway is very, very functional, and it maintains the plasma sodium concentration, but the effects are not visible, they are masked. The effects are masked by the ADH and thirst mechanism. Only in very, very extreme deficiency of aldosterone, there is so much loss of sodium that it leads to so much increased ADH secretion that it reabsorbs so much water that it causes dilution, and that dilution basically leads to decrease in concentration of sodium. So the final summary of the whole lecture is that the ADH and thirst mechanism are the main regulator of plasma sodium concentration. The angiotensin 2 and aldosterone have very, very minimal role except in very extreme deficiency of aldosterone. So that's all about the role of angiotensin 2 and aldosterone in controlling extracellular fluid osmolarity and sodium concentration. Thanks a lot for watching the video.